Chapter 35, Acquired Problems of the Newborn. These are your learning objectives for this chapter. When we talk about birth trauma, we're talking, or birth injuries, we're talking about the physical injuries sustained by a newborn actually during that labor and delivery process. The incidence of birth injuries in the United States is about 1.86 per 1,000 live births. So it doesn't happen too often, but the factors that predispose an infant to birth injuries are maternal risk factors, which may include their age, younger than 16, older than 35, a prima grava, first-time mom, if there's some type of uterine dysfunction that may cause or lead to prolonged or precipitous quick labor, preterm or post-term labor, and cephalopelvic disproportion. Oligohydramnios, which is the low amniotic fluid, can be a cause for birth trauma, as well as injuries that can result from some type of shoulder or some kind of dystocia because of fetal macrosomia, large fetus, or multiple gestations. So here's your stats being repeated again, 1.86 per 1,000 live births. One of the best ways to prevent birth traumas is to anticipate if something's going to happen. For instance, if you have a woman that has a macrosomic infant where the baby looks like it's going to be 9 pounds or greater, then you need to pre-assess, the best ways for delivery for this infant. And if you assess that there may be something like a shoulder dystocia, that you're going to have extra people around and needed people around when that woman delivers. So here are some of the a slide with the risk factors that we talked about: maternal age, oligohydramnios, the low fluid, macrosomia, etc. When you talk about difficult presentation, it may be a baby that is a breech presentation and we didn't know about it. The birth techniques, depending on how the baby's presenting, if it's the head presenting, is the chin well tucked, do you anticipate there's going to be use of forceps, etc. These are some of the obstetric birth techniques we can think about. Soft tissue injuries, and these are some that we see because of, and when we talk about soft tissue injuries, we're talking about the erythema, ecchymosis, petechiae, abrasions, lacerations. This picture here is showing marked bruising on the entire face of an infant born vaginally after a face presentation. There's less severe ecchymosis were present on the extremities. However, you see if the baby's face was directly present on the cervix, so if you can imagine when a provider or a nurse went in to feel what was presenting, instead of feeling something hard, they felt something soft and they felt this face. And the face is continually being pressed upon the cervix and the pelvic area, the pelvic bones. That is why this neonate appears with the bruising on their face. And because of this bruising on their face, they may be more at risk for becoming jaundice because of the breakdown of those red blood cells. If you look on page 763, table 35.1, there is an anatomic classification of birth injuries, looking at the scalp, and we talked before about caput, about a cephalohematoma, etc., and why those things happen. So take a look at those, but we had referred to these prior. Some of the skeletal injuries that we see in newborns, particularly when we talk about immature newborns, because their skulls are so flexible, it can withstand considerable molding. So, and so it's important to make sure that that molding results by being pushed back into the appropriate alignment. A clavicle bone is the most fractured bone during birth. And one reason why this bone is fractured is the difficulty with what we call a shoulder dystocia. A large baby, maybe an 8-pound, 13-ounce baby, trying to fit through the pelvic area, and sometimes the clavicle is fractured, so that baby can fit through. The humerus or the femur fracture, when those babies are assessed that those fractured are different, that those fracture happen, immobilization post-birth is accomplished for those babies just using slings and splints and being able to swaddle them appropriately. There are neurological fractures, brachial plexus injury, the phrenic nerve injury, and you see the picture of this baby with the facial palsy. And these fractures are assessed and determined when you're doing your neonatal assessment. Okay, you're looking at the head, you're feeling to see, is there caput here, is there cephalahematomas here, etc. And how you may think, well, how am I going to figure out if there's a clavicle fracture? You look at the baby when you're doing your assessment, when it's laying in the crib, and if they're flexing one arm and moving all the extremities, they're flexing, but they're not moving the other arm, then you want to assess, is there a fracture there? When you talk about brachial plexus injury, is the most common type of paralysis associated with a difficult birth and defined as a paralysis involving muscle of the upper extremities that follows some type of mechanical trauma due to spinal roots C5 through TI. This type of injury occurs, the brachial plexus injury occurs when there is a birth weight greater than 8 pounds, 13 ounces, vaginal breech birth, forceps, or vacuum-assisted birth. Duchenne paralysis or palsy is a result of injury to the upper plexus involving nerves C5 and C6, and this is caused by stretching or pulling the head away from the shoulder during a difficult birth. And this sometimes happens when someone sees that there's going to be a shoulder dystocia and the baby's clavicle is caught under the mom's suprapubic bone, and instead of following the typical steps for a shoulder dystocia to get that shoulder released, they just pull on the baby's neck, pull on the baby's head, and they can cause a paralysis with that. So the treatment with a brachial plexus injury is typically immobilization of the upper abdomen, proper positioning and range of motion. And they can get those gentle range of motion exercises. They can actually, with physical therapy, and parents can be taught how to do that. Facial paralysis, which is typically caused by pressure on the facial nerve during birth. And sometimes that is the risk factors for that is a prolonged second stage of the pushing and forceps assisted birth. So when these different trauma results are assessed, treatment involves assistance with feeding, prevention of damage, and continual reassessment to make sure that the baby and the injury is healing and healing accordingly. Some of the central nervous system injuries includes looking at intracranial hemorrhaging, which can occur in newborns. As a result of birth trauma, largely it's more likely to occur in large-term newborns. The risk factors again include vacuum or forceps-assisted delivery, a presence of coagulopathy, chorioamnitis, acidosis, subdural hematomas, which is a collection of blood in the subdural space, may also be produced by stretching and tearing of large veins in the cerebellum. And it can also be seen with forceps delivery, particularly with large, for gestational age infants. For most newborns, this injury is asymptomatic. And if symptoms are present, they occur about 24 to 48 hours after the baby's born. So usually before the baby goes home, and they may start having apnea, respiratory distress, altered neurological exam, or maybe even seizures. So that is why those assessments of the newborn continues even from the primary assessment that's done. Subarachnoid hemorrhage is a common cause of intracranial hemorrhage, and it occurs basically in term newborns. As a result of trauma in preterm newborns, we see it as hypoxia. This bleeding is basically from venous origin, and the underlying contusion, there's also an underlying contusion that can happen. Signs are, in some newborns, the signs are absent, and hemorrhaging is diagnosed only because of maybe an abnormal finding on a lumbar puncture. But in general, the nursing care of infants with intracranial hemorrhage is supportive and includes monitoring, particularly ventilation and IV therapy. And the most common cause of spinal cord injury in the neonate is a difficult breech delivery, a breech birth. However, today, typically breech births are when someone is, particularly primary births, if someone has a breech presentation, they could do something called a version to try before they go into labor to try to turn the baby so it's head down, or they offer the mom to have a cesarean section. So when we look at infants of diabetic moms, the pathophysiology, the mechanism that's basically responsible for problems in diabetic moms, it's not fully understood. In the early part of pregnancy, there's fluctuations in blood glucose levels, and episodes of ketoacidosis are believed to cause congenital anomalies, and that's primarily in moms that are type 1 diabetes. When moms with type 1 diabetes, when those mothers' pancreas cannot release sufficient insulin to meet increased demands, maternal hyperglycemia results. So therefore, there's an increased amount of glucose that cross the placenta and it stimulates the fetal pancreas to release insulin. And the combination of increased supply of maternal glucose and other nutrients, increased fetal insulin, results in excessive fetal growth. And that term is, and this is why diabetic moms have microsomic or large for gestational age babies, size babies. Microsomia is basically 8 pounds, 13 ounces, 4,000 grams. Hyperinsulinemia accounts for many of the problems experienced by the fetus or the newborn. When the maternal blood is more acidotic than the fetal blood, such as ketoacidosis, there's little carbon dioxide or oxygen exchange at the level of the placenta, and this can also lead to fetal death. The incidence of congenital anomalies among mothers with pre-gestational diabetes or diabetes type 1 is 3 to 5 times that of pregnant women who do not have diabetes. This risk of congenital malformations is related to the elevated glucose level during the period of organogenesis that happens between 5 and 8 weeks of gestation. So these congenital anomalies can be prevalent in pre-gestational diabetes moms, or the same as type 1 moms. However, moms that become diabetic during pregnancy is referred to as gestational diabetes, and that usually appears at about 26 weeks of pregnancy. Therefore, they do not have the congenital anomalies as the type 1 diabetes, because their fetuses have gone through the organogenesis, and their organs are developed before the diabetes exist. Even though healthcare, our prenatal healthcare, has evolved where it can help control maternal blood glucose today better than days of the past, still women that are diabetic have a typical large for gestational age or macrosomic baby. If you look on page 767 in your book, there is a great picture of a large for gestational age baby that was born to a diabetic mom. And what some of the characteristics that you can see is round, fat, chubby face. And it's very important when these babies are born that you take the baby's blood sugar within the first half hour to see, because they can develop hypoglycemia right away. So it's very important to look at this, to take this baby's blood sugar. And also the LGA babies or the macrosomic babies, they have an excessive shoulder size, and so they are at risk for a shoulder dystocia. And if they're at risk for a shoulder dystocia, they're at risk for that broken clavicle and those palsies. Respiratory distress syndrome in infants of mothers with diabetes is much less common than in the past because of the improved protocols to help manage maternal glucose levels. And so therefore, because of that better management today, infants born with women with well-controlled diabetes, their infants their respiratory distress syndrome risk is basically the same as the general population. Again, hypoglycemia is something that we're very concerned about in diabetic women, so it's very important to check the blood glucose level of those infants in the first first hour after birth, and to monitor that. Hypocalcemia and hypomagnesemia can occur in infants of mothers with insulin-dependent diabetics, and that usually but it's not present until about 48 to 72 hours. All infants, mothers with diabetes, they need careful observation for cardiomyopathy. Typically, mothers with type 1 diabetes during prenatal care may be given, their babies may have their fetuses may have an echocardiogram to look at the heart and to make sure that, to look at the 4 chambers of the heart, etc. So if there are any congenital anomalies, they can be detected early, and a plan can be made for delivery. There's typically 2 types of cardiomyopathies that can occur. They're hypertrophic and non-hypertrophic. Clinicians must be able to identify the type of lesion correctly so they can use appropriate therapy. Hypertrophic cardiomyopathy, that's characterized by a hypercontractile and thickened myocardium. In non-hypertrophic cardiomyopathy, the myocardium poorly contracts and is overstretched. And this is something that is monitored right after birth. And it's typical that the type 1 diabetic moms, as indicated before, will have an echocardiogram so they can monitor the vessels of the heart while they can do that monitoring in utero. And additionally, diabetic moms, their infants are at increased risk for developing polycythemia and therefore hyperbilirubinemia. The hyperinsulinemia increases the newborn's metabolic rate, which increases oxygen demand, leading to a mild chronic hypoxemia. And because of the hypoxemia, it stimulates the red blood cells. And the greater number of red blood cells to be hemolyzed increases the potential bilirubin load that the neonate must clear. So therefore, the neonate may experience the hyperbilirubinemia. And in addition to that, if there was a shoulder dystocia, a dystocia because of a macrosomic infant, that can also increase the bilirubin load. So these babies are at an increased risk for developing jaundice. So basically, the nursing intervention is to monitor these babies, monitor their respiratory status for RDS, listening to their heart, monitoring if they're more a little yellowish for the jaundice, etc. And looking at to see if there's any fractures with the brachius, if there's any neurological plexes, paralysis that's going on. Neonatal sepsis is one of the most significant causes of neonatal mortality and morbidity. This is defined as systemic inflammatory response, or SIRS, that occurs secondary to infection. Some of the signs and symptoms are hypothermia or fever, tachypnea, which is that increased respiration, hyperventilation, tachycardia, high or low white blood cell count. The early onset may be defined as invasive bacterial infection of the blood or the cerebral spinal fluid, and this can happen within the first 7 days of life. Some of the most common organisms are GBS, which is group beta strep, or E. coli, and together those account for about 70% of the infections. Other infections may include Streptococcus viridin, Streptococcus pneumoniae, and some risk factors include prematurity, If there was prolonged rupture of membranes, let's say mom's membranes were ruptured greater than 18 hours, 24 hours, procedures that were done during the pregnancy or labor, possibly resuscitation at birth, maternal fever, and GBS colonization. Late onset, which occur from 70 to 30 days of age, can include maternal infection or healthcare acquired infection, and those organisms are typically staph, Klebsiella, E. coli, could be Candida. If you look on page 769, table 35.2, there's risk factors for neonate sepsis, and familiarize yourself with those. Another viral infections, which include cytomegalovirus, varicella, rubella, etc. And those infections are CMV, cytomegalovirus. Those infections are viral, but can, particularly cytomegalovirus, there is a picture on page 770 that has an infant that has a rash because of a cytomegalovirus infection. And those occur in about 0.5 to 1% of live births in the U.S. Cytomegalovirus can be transmitted during birth or through breast milk while the mother has acute CMV infection. The infections are typically asymptomatic at birth, and the death occurs in about 3 to 10% of infants with symptomatic CMV. Varicella, chickenpox, is an acute infectious disease caused by the varicella zoster virus and highly contagious human herpes virus. The virus can remain in the body as a latent infection, and usually in the sensory ganglia. About 95% of women in the childbearing years are immune to varicella. However, it can be contracted and passed on to the infant. Rubella, congenital rubella syndrome in the United States, it's rare, and it's mainly because, many people have been immunized against rubella. And the risk of congenital infected infants, it varies with it because of the gestational age of the fetus when the maternal infection occurs. If the rubella infection is mild, there'd be minimal or no effect for the fetus. Congenital rubella syndrome, could include cataracts or glaucoma, hearing loss, and cardiac defects. One of the things that you may do, women that, because rubella can be have very, very bad symptoms for the newborn. Rubella, if a woman is found to be rubella immune during prenatal care, that is usually put in her chart. So postpartum, she is given a rubella vaccine to help protect her. So, for the next pregnancy. Hepatitis B, the perinatal transmission from an infected mother to her fetus, usually occurs during the blood exposure that occurs during labor and birth. And the risk of passing HPV to the newborn is about 70 to 90% when the mother is seropositive. Transmission can occur through breast milk. And the CDC recommends universal HPV immunization of all neonates prior to hospital discharge and subsequent completion of the recommended vaccine series. Any infant born to a mother who is seropositive for HPV should receive HPV vaccine and hepatitis B immunoglobulins within 12 hours after birth and should complete the recommended vaccine series, followed by post-vaccination serologic testing. So that's another series of injections you might be able to give the baby before they leave on your postpartum units. As far as HIV is concerned, the passage of HIV among newborns has declined significantly since the 1990s, particularly in the US, and particularly if a pregnant woman with HIV takes her antiviral medication during pregnancy. There is the likelihood of probably maybe approximately 1% of infants that are infected with HIV. Again, your HIV moms, it is encouraged that they do not breastfeed. However, as indicated before, that's in the United States. In women that live in developing countries where they do not have necessarily the opportunity to have formula-fed milk, they are, the weight of providing breast milk outweighs the chance of the infants becoming infected. And typically the HIV infected neonate is asymptomatic at birth, and early onset could be detected within 48 hours. And the infants may develop opportunistic infections such as candida and pneumocystis pneumonia if they are infected. Herpes simplex infections can cause significant morbidity and mortality in newborns. HSV infections in newborns occur in about 1 in 3,000 to 1 in 20,000 live births. Some of the congenital infection is rare and is characterized in utero by destruction of normally formed organs, which therefore result in IUGR, microcephaly, hydroencephaly, or fetal death. HSV is transmitted from mother to neonate through viral shedding during labor and birth. Many times, if a woman has a history of HSV, and when she appears to triage, let's say she's in labor, they will, and if she's planning to have a vaginal delivery, they will assess her pelvic area, her perineum, to see if there are any lesions. And if there's no lesions in that area where the baby's coming through, she may be able to birth vaginally. However, if there are lesions, then they do a C-section for birth. Enteroviruses include Coxsackie viruses, echoviruses, and others. And typically this happens, baby may become infected as in utero transmission. They're more likely to occur. And during and after birth through contact with the maternal blood, cervical or vaginal secretions. There's usually an incubation period within 3 to 6 days, so this may not be something that's seen in the hospital, but on that 1 to 2 week newborn visit to the office, there may be some presenting symptoms of fever, irritability, lethargy, poor feeding, rash, etc. Parvovirus, which is the parvovirus B19 infection. In older children, you may have heard of the fifth disease or the slap cheek illness because it looks like there's a rash on their cheek. And this infection is transmitted by vertical transmission from mother to fetus, contact with respiratory tract secretions, and exposure to blood or blood products. And during pregnancy, this infection can actually result in miscarriage, fetal anemia, hydrops fetalis, IUGR, or stillbirth. And it does not believe to appear as a teratogen. In most cases with paravirus B19, only supportive care is needed. And if there's hydrops fatalis, if that is an issue, then a intrauterine blood transfusion may be necessary. Influenza, women are encouraged to get flu shots, and if they get a flu shot while they're pregnant, that helps protect the developing fetus. The complications to the fetus appears to correlate with the severity of the maternal infection. And if a pregnant woman, depending on how bad the infection is, it may result during the first trimester in miscarriage, preterm birth, or stillbirth. So the influenza vaccine is recommended for all pregnant women. Newborns who become ill with influenza are at a high risk for severe complications. And the separation from mom after the baby's born should continue until the mom has received at least 48 hours of antiviral medication. The Zika virus, something that appeared first about 5 years ago, is recognized as a mosquito-borne teratogen that can cause fetal loss, microcephaly, and other serious neurologic defects. And the most severely affected fetuses with congenital Zika syndrome, they have microcephaly, brain, ocular, and optic nerve abnormalities, congenital contractures, and other neurological problems such as hearing loss, swallowing dysfunction, hypertonia, hypotonia, irritability, and tremors. And if you can remember back about 5 years ago, you saw, I believe it was in South America, in Brazil, because of the climate, water stagnation, and the many mosquitoes that they had there, the problems that they had with babies being born with these deformities because of Zika. So when we move on to bacterial infections, one of the biggest ones that we're concerned about, Group B strep, is a leading cause of perinatal infections. And women are screened at typically at 36 weeks for Group B strep. And strep is not, Group B strep is a normal some women are colonized with that bacteria in their vaginal area or maybe in their urine, and it does not cause the woman any problems. However, when we do test on women and find that they do have Group B strep, what we do is let them know, indicate that in their chart, so they get antibiotics in labor. That's when we treat known Group B strep candidates, is during labor. We give them antibiotics. The idea is to give them 2 doses of antibiotics IV before baby's born. So we kill the Group B strep before baby comes through there. This is only for women that are having a vaginal delivery. If they're planning on a C-section, we do not give them the antibiotics in labor. But some of the risk factors for the development of early onset GBS infection include now preterm birth. Like I said, we check the women at 36 weeks, but if someone is 32 weeks, we haven't done her GBS screening yet. So if they're having a preterm birth, we treat them as if we know that they have Group B strep. Someone that had rupture of the membranes for more than 18 hours, those women may be treated for Group B strep if it's prior to that 36 week. Some of the signs and symptoms that we see for Group B streps is we monitor the infant. We do blood cultures on the infant also, and we monitor the infant when we see late onset infections, that can be associated with meningitis, septic arthritis, but typically symptoms of the infection, we'll see severe respiratory distress. These infants can develop a pneumonia, shock, or meningitis. So this is why when you do your assessment, and one of the things that you get in your report that happened in labor and delivery, if mom was GBS positive, if she was treated, or if there was ever any question about beta strep. E. coli is the second most common pathogen that causes sepsis and meningitis in newborn. E. coli typically is found in the GI tract, and it can cause a variety of neonatal infections, including diarrheal illness, pneumonia, and peritonitis. The neonates may pick up E. coli from the maternal vaginal or rectum area, and they get that through birth. Most staph infections in the newborn develop after the first 72 hours of life. And those infections can show up as a conjunctivitis, redness in the eye, drainage from the eye. But Staph aureus can also cause problems such as abscesses, osteomyelitis, endocarditis, septic arthritis. And it's important you're looking at, so you look at these,